This lecture will be covering management of impairments of the lower leg and foot. So as we know, when we have a patient who has a lower leg dysfunction, quite often the first thing we see is a disturbance or dysfunction in their gait. So just to review, and again this is a review, so gait can be broken down into weight acceptance, where the foot pronates to absorb shock. And the amount of pronation certainly varies, but we need that pronation to mold to the surface and absorb that shock. During mid-stance, pronation then ends. During terminal stance, there is movement into supination. Now, the range of motion that's necessary for normal gait, we need approximately 10 degrees of dorsiflexion, 4 to 6 degrees of eversion, and approximately 8 to 12 degrees of inversion. The foot needs to pronate and supinate about 6 to 8 degrees from that neutral position. And you've seen this picture before out of Newman, looking at the different phases of stance and stride, giving you the periods of initial contact, opposite toe off, heel rise, opposite initial contact, toe off, the feet are adjacent, the tibia is vertical, and then the next initial contact. So when we're examining somebody's gait and we notice that they have excessive supination, you should have a pop-up window that tells you, well, there are intrinsic things and there are extrinsic things that could be contributing to what we're seeing. Intrinsic meaning coming from within the foot, extrinsic meaning coming from outside the foot. So when we see excessive supination, we know that this could be seen due to a compensation of something inside the foot, including a plantar flex first ray and forefoot valgus. We could also see an excessively supinated foot during weight bearing in a foot that's uncompensated. For instance, if you had forefoot varus or rear foot varus that was uncompensated, you could see excessive supination during gait. Some extrinsic factors that can contribute to excessive supination include femoral retroversion, uncompensated tibial varum, some neurological disorders, and certainly a leg length discrepancy, the shorter foot being the excessively supinated foot. We could also see excessive pronation, and again we should have a pop-up window indicating what are the intrinsic factors that could be contributing, including compensated forefoot varus and compensated rear foot varus. Extrinsically, we know if a patient has decreased dorsiflexion, the foot will pronate more to be able to bring the foot forward. There could be muscle weakness that's contributing to excessive pronation, and you should be thinking about what muscle groups would be weak if we saw excessive pronation. There could be increased femoral aneversion, and there can certainly be overall laxity within the foot. So just to give you an idea, you should inspect the person's footwear inside and out for wear and tears, because those patterns of increased contact or increased wear and tear are a clue. So in a normally aligned foot, there should be even distribution of weight over the met heads and slightly more on the lateral aspect of the heel. When you put a shoe down, they should sit level. So again, you're looking for abnormal wear and tear inside and outside of the shoe. Normally, in a normally aligned foot, the stability type shoe is semi-curved, and usually the midsole is a different color from the rest of the shoe. In a pronated foot, you need more motion control. So the shoe straight shape is a little bit more of like you have a rigid heel counter. This is for somebody who's got that weak foot, the hypermobile foot, or a flat foot. Someone who has a stiff or supinated foot, they need more of a cushioned shoe that looks curved in appearance from heel to toe and has a flexible heel counter. So this helps in absorbing shock, because if we're more supinated, we're not getting as much pronation as we need to absorb that shock. So we'll certainly see a lot of overuse syndromes in the foot, which can have both intrinsic or extrinsic factors that are contributing to it. Once this imbalance is created, We get this, so we tend to see, sorry, let me take a step back, in the overuse syndromes, we tend to see these in swimmers, cycling, and running. You know, these are sports that continue to grow in popularity, but they're repetitive type activities that can cause overuse syndrome. So etiology, we have some kind of overuse where there's tissue microtrauma and we get this inflammation that can be acute or chronic. The chronic inflammation can lead to cell atrophy. As I mentioned, there are intrinsic or extrinsic factors that can be contributed. So we get this imbalance with this microtrauma resulting, and we begin this inflammatory response. So we need to think about what are some of the possible biomechanical factors that may be contributing to overuse syndromes. And what we mean by that is looking at the intrinsic alignment of the foot, doing a biomechanical foot assessment. So how does the rear foot look in reference to the lower leg? How does the forefoot look in reference to the rear foot? How is the position of that first ray? And how is the mobility of that first ray? So some of the things that we see in the foot and ankle, we see shin splints, we certainly see stress fractures, compartment syndromes, chondromalacia are softening. And as we mentioned before, ITB friction syndrome, you may consider more of a knee dysfunction, but certainly can relate to the foot and ankle. Common sites for stress fractures in the foot, usually the metatarsals, the calcaneus, or certainly the tibia. If you're suspicious of that, immediately get them off that foot and let them have some diagnostic imaging to confirm. So, as we know, there are many, many muscles that surround the foot and ankle, and any kind of imbalance that can be created can cause a strain. A muscle strain, just so we are all on the same page, we know is a contractile lesion. So if you're suspicious of a contractile lesion, you should be looking for patterns. So active range of motion using that muscle, resisted motion using that muscle group will be uncomfortable for your patient. Stretching that particular muscle will also be uncomfortable. Resisted isometrics done in neutral is where we're kind of in that neutral position. We're trying to avoid irritation of inert structures. So resisted isometrics, you're looking for weak or strong, pain-free or painful. But you would expect that resisted isometrics would cause dysfunction or complaints of pain in a patient with a muscle strain. So you should really be thinking about any of the muscles that cross the foot and ankle and how they may present if they've been strained. So just to give you an idea of the incidence and epidemiology of foot and ankle injuries, so this particular study evaluated the injury records of all varsity sports at a single NCAA Division I athletics program, and they included over 1,000 athletes participating in 37 sports. So they took detailed injury data, and they had one of those secure web-based, and they followed these individuals over a 2-year period. They looked at the injury exposure or athletic exposure and any injuries that occurred, any missed days. Did the patient or the subject have to go see a physician? Did they have any imaging? And whether that injury required surgery. So they were then able to report injury incidents, frequency distributions, as well as which types of injuries did they see more often. So during that 2-year period, not that you need to know this, but just to give you an idea, almost 4,000 musculoskeletal injuries were recorded. Out of those injuries, about 27% were foot and ankle injuries, a little over 1,000. Of the foot and ankle injuries, 21% of them caused the athlete to miss at least 1 day of participation, with an average of 12.3 days time loss from that sport. I would never ask you that information, it's just for your own knowledge. Furthermore, 27% of the athletes with foot and ankle injuries were referred for an office evaluation by a physician, and 84% of those individuals required radiological imaging. The overall injury incident was about 3.8 per 1,000 athletic exposures. When we talk about athletic exposures, that could be a practice and certainly a game. The 4 sports with the highest incidence rate, meaning like greater than 75th percentile, were women's gymnastics, women's cross country, women's soccer, and then men's cross country. And the most frequently occurring foot and ankle injuries were ankle ligament injuries, tendinopathies, or even fasciopathies, and bone stress injuries. So foot and ankle injuries in Division I athletics was 27% of the total musculoskeletal injuries that occurred over a 2-year period, with 21% of these injuries resulting in missed time. And that's a lot. So there were significantly higher foot and ankle injury incidence rates and more missed time in female athletes in women's sports. So moving on to the most common injury that was reported. So we have ankle sprains. Just to give you an idea, about 23,000 ankle sprains occur every day. And lateral ankle sprains account certainly for more than 85% of them, and usually it involves a individual going down on a plantar flex and inverted foot. And as you can see here, most often the ATFL is injured, followed by a combination of the two, ATFL and CFL. The literature notes that up to about 70% of patients have a repetitive sprain, so they fall into the category of chronic ankle insufficiency. It usually takes about 6 weeks to 3 months to heal, and obviously that depends on the severity of the sprain, if it's a grade 1, 2, or 3. From 6 weeks to 1 year, a large percent of patients still noted objective mechanical laxity, meaning they had increased excursion, and subjective ankle instability, meaning they noted that they felt a little unstable. So just to review your grades of a sprain. So grade 1 is minor tearing with no functional loss of ankle stability, meaning no increased excursion. You wouldn't have any positive joint play assessments or special tests. Grade 2, you get a partial tearing of the ligament with moderate instability. Now, partial tear can be anything from a few fibers to almost all of it, but with this individual, you would get increased excursion during joint play or certainly special tests. And a grade 3 is a complete rupture with significant functional instability. So in treating an ankle sprain, these are just some general guidelines, but in the early phase, this can range to 1 to up to a week. This is your price. You're doing protective healing. You want to prevent that ankle from getting any further injury. So you're trying to decrease pain, inflammation, and swelling. You're trying to get them back to full weight bearing, but they may need to use crutches in this early stage, especially if it's going to protect them and not let them get injured even more. We're going to try to work on getting their full range of motion back and preventing muscle atrophy. So we want them during this time not to lose their overall functional level, and we want to get them to be doing most of their exercises on their own. In the subacute phase, which usually begins after a week, and that too can last about a week, we're continuing to do the modalities to decrease the pain and inflammation, and certainly to get the muscles around that particular, around the area to function properly. We continue to progress weight bearing and pain-free range of motion, and we'll be doing strengthening and proprioception exercises to the entire lower extremity, especially the hip, because we know weakness there can put more forces across the knee and ankle. The rehabilitation phase can last up to 3 weeks, and we're continuing all the progressive strengthening and trying to work on their balance and proprioception, which we know is usually limited, especially after repetitive trauma. And then individuals return to activities anywhere from a week and a half to up to 6 weeks, again, depending on the grade of the sprain. But you really want to make sure that they're doing lateral activities and plyometric activities where you're sure that they're absorbing force as well and they're able to cut without complaints of pain or any movement dysfunction. So this just gives you a little bit of an idea of exercise progressions in this patient population, and this kind of can be used across lower extremity injuries, but usually we start with isometric exercises in those neutral, stress-free zones. Then we progress to going throughout the range of motion. We then it certainly doesn't have to be you end isometrics and begin isotonics, but typically you can start when you start to feel that the person can accept a decent amount of resistance with isometrics. You can move on to isotonics, again starting in the stress-free neutral positions, moving towards those stressful end range where the ligaments would certainly become taut. Start with low resistance, move to high, start with slow velocity, move to high velocity. And if you have the capability of using isokinetic exercises, you would certainly once again start in the neutral stress-free positions and move towards those end range or stressful positions. Then you really want to work on multi-directional activities, working on balance and proprioception, and getting them to do more sport-specific or job-specific activities that they need to return to. So this was a study that was done in 2009 looking at a 4-week exercise program with tubing on individuals with a history of ankle sprains. And here they actually grouped their subjects into one of 4 categories. So first they were randomized either had patients who had chronic ankle instability, and you can see what that was defined as. They had 1 or more ankle sprains within the past year. And had at least 2 or more sprains within the past 3 years. And then you had your healthy normals who did not have ankle sprains in the past 3 years. So out of those 20 in each group, they were then subgrouped based on, so those with CAI, half of them were put in the exercise group and half of them were put in control. Same thing with your healthy normals. Half of them were put in an exercise group, half of them were put in a control group of which they did not have exercise. This just gives you an idea of the tubing exercise that they had them do. They did a front pull, also certainly did a back pull, side pulls, pulling in to add adduction and abduction, like a resisted crossover exercise. They also looked at the outcome measure was looking at balance as measured on a force plate during single limb stance. The individual would stand on that leg for about 20 seconds. On the foot that was considered, that had the chronic ankle instability, and while they were standing on this leg, they were focusing on a circle that was about 3 meters away at eye level. And what you can look at here is this is the total travel distance by time. So you want to have a smaller excursion of. While you're standing on that one leg, you want a smaller travel distance. So you can see the orange is for both the healthy normal group and the blue is for the chronic ankle insufficiency group. But you can see the healthy normal group certainly had a smaller travel distance compared to the chronic ankle insufficiency, indicating that their sway or their ability to maintain balance was altered after having these ankle sprains. This particular study, they were testing the hypothesis that ankles with functional instability will demonstrate slower muscle reaction times than their contralateral, what they call stable ankle or SA, and stable healthy controls to simulate like a non-pathological ankle sprain. So they looked at 19 male volunteers with a history of unilateral ankle sprain and functional ankle instability, also known as FAI here, not FAI of the hip, okay? And they had 19 healthy male controls that they performed reaction time tests on a platform that kind of simulated that plantar flexion inversion sprain mechanism. So participants certainly had informed consent. Reaction time and muscle activity data were reported for the FAI unstable and stable ankles and certainly the control group. And they found that reaction times of the peroneus longus, peroneus brevis, and tibialis anterior in those with unstable ankles was significantly slower than the stable ankles, meaning the patient's other side, as well as a control group's dominant ankle. The reaction time of the support limb, peroneus longus, TA, and extensor digitorum muscles of the unstable ankle were slower than the dominant ankle. So slower reaction times acting to support that unstable ankle may put the contralateral, so you may have one side that is called noted as the unstable ankle. If you have slower reaction times on that side, you're kind of putting your other side or your stable ankle at increased risk of an ankle sprain. So when we rehab a lateral ankle sprain, we should include certainly strengthening of the everters, the peroneals, extensor digitorum longus at the subtalar joint, and the dorsiflexors, TA, extensor digitorum longus at the talocrural joint, working on strength, working on increasing reaction time of both the injured, and make sure that the uninjured or the stable ankle is certainly not losing any reaction time or making it predisposed to future injury. Syndesmotic injuries, certainly you may have heard of this more as maybe a high ankle sprain. So here we have the mechanism of injury is this external rotation and excessive dorsiflexion of the foot. We also get here when we have external rotation and excessive dorsiflexion, you're putting increased strain on the deltoid ligament. It could also lead to a fibula fracture. Not very common, but it occurs in approximately 10% of ankle injuries. So the external rotation, and then there's, like I said, there's external rotation, excessive dorsiflexion of the foot on the leg, and that has been reported as the most common mechanism of injury here. The injury is most often incurred by individuals who participate in skiing, football, soccer, and other sport activities, and certainly playing on turf. With these individuals, you want them immediately non-weight bearing with crutches or a walker, because it's imperative to prevent that further talar and fibular rotation, as well as disruption of the syndesmotic soft tissues. Usually these individuals are placed in a posterior splint with the ankle positioned in neutral dorsiflexion plantar flexion to provide that stability to the distal tib-fib syndesmosis. Early programs involve early rigid immobilization with with pain relief strategies. You then follow that with your strengthening and your balance training. Sometimes a heel lift or a posterior splint can be used to avoid separation of that distal syndesmosis, which is induced by that excessive dorsiflexion of the ankle joint. So conservative treatment is usually recommended for these individuals in the absence of fracture. So immediately get them non-weight bearing. There's early rigid immobilization, like I indicated, posterior splint, while in non-weight bearing and a heel lift once weight bearing is initiated you're trying to avoid that separation of the distal syndesmosis, which occurs with excessive dorsiflexion of the ankle. So that's why we can splint them early on. You're going to do your modalities to decrease pain, try to work on getting their range of motion back, and once they're able to fully weight bear, you begin your pain-free strengthening and stretching and working on balance training. This just gives you kind of a breakdown of the different phases for someone who has sustained a syndesmotic injury. You can see it's much more conservative than a typical ankle sprain, lateral ankle sprain. So moving on to tendinopathies, obviously the biggest tendinopathy in the foot and ankle is the Achilles tendinopathy. So we can have paratendinitis, which is that early inflammatory process. So that's the individual where we're using modalities. We're going to limit their activity to try to decrease that inflammation. We're going to stretch and restore range of motion, and we give them a gradual return to activity. Someone who, we now talk about chronic phases. We're not talking about, this chronic inflammation really doesn't exist. Tendonosis is where it's non-inflammatory, that we're getting degeneration of that intratendon. We get some vascular changes. This individual has that low-level chronic pain. We get the tendon thickening, and when examined underneath the microscope, we see an irregular structure to these tendons. We really want to be looking at their biomechanical foot assessment to see if there's any intrinsic things that are contributing to this individual's the reason why they have this tendinosis. So a couple of different studies looking at what you should do when you have somebody with Achilles tendon, chronic Achilles tendon pain. So this study looked at doing eccentric calf muscle training. So they had 78 individuals who had mid-portion Achilles tendinosis versus 30 individuals who had insertional Achilles tendon pain. So really, how do you categorize these two? It's when you're asking the patient where they have discomfort. As you can imagine, the insertional Achilles tendon pain is right where it inserts onto the calcaneus, versus usually mid-portion is about 2 inches proximal to that. So this study looked at doing 12 weeks of eccentric calf training. So they did 3 sets of 15. They did it twice a day for 7 days for 12 weeks. And when they looked at the success of the two groups, and success was defined as a significant reduction in pain with activity and being able to return to the pre-injury activity level. There was 89% success in the mid-portion group, whereas there was only 32% success in the insertional group. We initially wasn't sure why. So just giving you the idea, these were the exercises that they did. So they did eccentric calf lowering off of a step, going into end range. So there was also studies looking at concentric versus eccentric. This study had 44 patients with chronic Achilles tendinosis. One group did eccentric work, the other group did concentric training, and the results that they found, the eccentric group did significantly better compared to the concentric group, meaning 82% of them were defined as being successful, whereas 36% of the concentric group. And here they looked at patient satisfaction and again returned to previous level of activity. So this training training include tubing. So here we have concentric training activities in the first weeks, doing heel raises in a seated position. Then we did heel raises in a standing position, stretching into dorsiflexion. And in weeks 6 to 12, they did rope skipping 3 times for a minute, 3 times at a slow speed. They also they called these side jumps, the picture on the right, but really, as we know, that's really hopping, or really leaping from right to left. So they did 3 sets of 20 of these, and they considered this concentric, and really, if you think about it when you land on it, that really is certainly eccentric activity. So this study was a follow-up study to the original one where they looked at insertional versus mid-portion Achilles tendinosis. And if you recall, if you go back a couple of slides, they did eccentric loading into the end range position, and they found that individuals with mid-portion did so much better. So they modified the protocol here, and what they did for the individuals with insertional Achilles tendinosis, they had them do eccentric training, but they did not load into that end range dorsiflexion position. So they would lower, but they would only go to neutral. And in this case, we had 67% of the patients had successful results. So the modification here was that they avoided that end range dorsiflexion, because the poor results that they had in the previous study were thought to be because of mechanical impingement between that prominent calcaneus and the tendon and the bursa when the ankle was in that end range dorsiflex position. So they modified the eccentric training to not have that end range dorsiflexion to avoid that possible mechanical impingement. Another protocol that you may hear about is the Alfredson Protocol. It's a large amount of activities. They did 3 sets of 15 with the knee flex and 3 sets of 15 with the knee extended, and they did this twice a day. So you're looking at 180 eccentric heel drops a day. Patients were encouraged to continue with these exercises, even if if they experienced pain, but certainly told to stop if the pain became disabling. So this study by Stevens compared this Alfredson protocol to a protocol which was more like do as much as you can, like a tolerable volume over a 6-week period. And Stevens' study found that there was no difference in scores after 6 weeks. Both groups got better. At 3 weeks, the do as tolerated, or do what you can, was better than that standard Alfredson protocol. So patient tolerance of exercise may need to be considered when determining what the proper dosage for a program of eccentric heel drop exercises when you're looking at individuals with that mid-portion Achilles tendinopathy. I think most of us tend to say, we don't want them pushing through pain, so just to look at their form and to do as tolerated if the results are similar. So again, this is just, I want to highlight that the orthopedic section of the APTA has some clinical guidelines that are posted on their website, and I've posted the links on Canvas under links to resources. So there is a clinical guideline titled Achilles Pain, Stiffness, and Muscle Power Deficits, Achilles Tendonitis. Now, this was originally done, I believe, in 2010, but now this is a draft update to that, and they were looking at interventions for, different interventions that have been known to be used in this population and to try to look at the evidence of its effectiveness. So you can see here it talks about iontophoresis being a level B. Certainly, the thought is to use iontophoresis with dexamethasone to decrease pain. Manual therapy, clinicians certainly can use joint and soft tissue mobilizations to reduce pain and mobility. Really no recommendations for heel lifts in this population because there's contradictory evidence for the use of heel lifts in this population. In terms of exercises, clinicians should use either eccentric or heavy load, slow speed exercise programs for Achilles tendinopathy to certainly decrease pain and increase function. The load, the speed, and the frequency. Many of the studies this wasn't controlled for, so just be a little careful and use your own judgment here, but you want to make sure that you optimize the parameters for your particular patient. But patients need to exercise at least twice a week within their pain tolerance. Plantar flexor stretching with the knee flexed and extended is certainly encouraged to improve outcomes, and certainly education and counseling on what's going on, and certainly looking at their BMI and the overall cardiac function. Night splints have not been recommended to reduce pain in patients. Low-level laser therapy can be used in patients with that mid-portion Achilles tendinopathy after other recommendations have failed to improve pain, stiffness, or function. So not your first avenue, but if you're kind of stuck and other things aren't going your way. You may use orthotics, especially when you do a biomechanical foot assessment and you feel that there's intrinsic factors that are contributing to pain. Taping, you see here the evidence, the level of evidence is kind of low because therapeutic elastic tape has not been recommended to reduce pain in this population, and you can certainly use taping to decrease strain on the Achilles tendon, but it has certainly low-level evidence. And certainly for neuromuscular rehab, targeting lower extremity impairments may lead to those abnormal kinetics or kinematics. And dry needling for patients with mid-portion Achilles tendinopathy for over 3 months has been found to have some effectiveness. So you could use a combined, dry needling with ultrasound as well as eccentric exercises to decrease pain. Another muscle group another muscle that has, we find frequent tendinopathy is the posterior tibial tendonosis, and then, as we know, there are different stages and goals for treatment, but overall goals are to reduce symptoms, return our patient to activity, improve alignment, and prevent deformity, and certainly educate our patient to what's going on. So depending on the grade, but most patients, typically patients are immobilized and they have footwear modifications. They may be put in an orthotic or an AFO, but we need to stretch the Achilles with the foot in supination. We need to strengthen the inverters, muscles of the arch, hip extensors, and abductors because they've been found to be weak in this population, especially focusing on the eccentric component of these muscle groups. And we want to use orthotics to decrease the tissue stress that's going across this region. So make sure you're addressing the stretching, certainly the support to decrease stress, and work on strengthening. So this was a study that was looking at individuals with posterior tibial tendon dysfunction, that's the blue and the orange on the left, and then we have individuals who healthy controls on the right. The blue is looking at the involved limb, the orange is the uninvolved limb, and then in the control group, the green is the dominant limb and the yellow is the non-dominant limb. So we're looking at the number of the single heel raises that the individuals were able to do on both sides for both groups, and you can see there was a significant effect for side and group, indicating that both groups performed fewer repetitions on the involved and that or dominant limb, and that individuals with posterior tibial tendon dysfunction perform fewer than the controls. So you can see a difference from side to side, whether the individual had PTTD or they were healthy, and then there was certainly controls were able to do more. Looking at hip extensor and abductor strength, again between these groups, we see that there is a significant increase in hip extensor and abductor strength in healthy controls. So once again, glute max, glute med. And this is just endurance, looking at hip muscle performance, and again in those extensors and abductors, and you can see once again that the controls had increased endurance in the extensors and abductors. Heel pain or plantar fasciitis is the most common foot condition that occurs, as you could see, in approximately 2 million Americans per year. Overall, 10% of the general population. Those with limited dorsiflexion and increased BMI are at higher risk. Usually the patient will have pain on the plantar medial heel region. When they first get out of bed or they first get up from being inactive, they complain of pain with that, and then certainly with prolonged weight bearing. And we usually see flare-ups when they all of a sudden have an increase in weight-bearing activities. So pronation tends to cause increased mobility in the foot, thereby increasing the level of stresses applied to the various musculofascia and soft tissue structures around, or I should say associated with plantar fasciitis. So footwear, foot orthosis, and foot strapping have certainly been used to reduce the amount of foot pronation during activity, which would then decrease the stresses applied to these inflamed tissues. So you want to reduce pain and inflammation. You can certainly have patients on medication, and we can use our modalities. We can use footwear or strapping or an orthosis to try to reduce, think about that tissue stress model. We want to restore flexibility and strength to the involved tissue. In this study by McPoyle, showed that within a year period, 80% of patients reported a resolution of symptoms. Another study by Porter noted that they had 90-95% reduction in symptoms. So these are some of the typical interventions that you see with individuals who have plantar fasciitis. So dexamethasone has been known to decrease inflammation and pain. Manual therapy, including joint mobilization, soft tissue mobilization, and neural mobilization, has provided short-term relief in the first few months. Taping, either calcaneal or low dye taping, has been shown to give short-term relief, roughly 7 to 10 days. Orthotic devices, the prefabricated or even the custom, provide short-term relief, and we're talking around 3 months, but there was no differences in relief between the prefab and the custom-made orthoses, and certainly no evidence that either of these two provided long-term relief. Night splints, you can think to use night splints in patients who have had the plantar fasciitis symptoms for more than 6 months, and at that time try it for a period of 1 to 3 months, but if you don't see relief at that point, then you're not going to probably get an effective resolution with night splints. This study was looking at different kinds of stretching and its ability to decrease symptoms. So DiGiovanni looked at gastrocsoleus stretching as well as the plantar fascia specific stretch. And the plantar fascia specific stretch is when the patient would passively extend their great toe and then dorsiflex the foot at the same time. So they roughly had 100 participants, half in each group. Both received over-the-counter soft insoles. They had 3 weeks of NSAIDs, and they were educated on what was going on and the importance of doing their exercises. They were told to, whichever group they were in, they were to stretch for approximately 10 seconds. Repeat that 10 times, 3 times a day. So that's a lot of stretching, but for a shorter period. Heel pain was eliminated or significantly improved in over half of the individuals with the plantar fascia specific stretch, and only 22% of those who did the gastroc soleus stretching. And the reason why it's starred here is I just want to let you know that this was not a blinded study. There was a high dropout, and they only analyzed those individuals who completed 8 weeks of the trial. So the results certainly indicated that there were no differences between, the two groups initially had no differences between them, but there was a significant reduction in pain in those individuals who did the plantar fascia specific stretch. So restoring muscle strength should certainly include activities for both the extrinsic and the intrinsic muscles of the involved foot. Strengthening exercises for the extrinsic muscles should emphasize the inverter and the plantar flexor muscle groups, but certainly don't just look at the foot and ankle. Make sure you're looking up above and the hip extensors and abductors as well. This is just your levels of evidence. This is another clinical guideline available through the the Journal of Orthopedic and Sports PT, and I do have the link on Canvas. This is just looking at heel pain, plantar fasciitis, and it goes through the summary of recommendations for the typical interventions that you see for individuals with plantar fasciitis. Moving on to ankle fractures, this is just a very broad category. Overall, the key element in the acute treatment of talocrural joint fractures is to restore that tibio-talar anatomical alignment. So we are reducing pain and inflammation with modalities and retrograde massage. You can do edema massage, scar mobilization, and edema, other activities to reduce that edema. We'll begin with active range of motion in mid-range, doing low intensity, high reps. But as they begin to their function starts to normalize, we're going to increase their range of motion exercises to make, to get increased range of motion and make sure certainly that it's tolerable. Now, there's many types of ankle fractures. Usually when we're looking at the talocrural joint, we talk about lateral fractures, medial fractures, bimalleolar or trimalleolar. So lateral fractures, usually if their surgery is performed, if there's static or dynamic incongruence, all others generally have good results when they're put in a closed reduction. So most often lateral fractures, and here we're talking about the fibular fractures, usually they're treated with a cast or boot. The only time they have surgery is if there's that things aren't lined up. When we talk about medial fractures, we're talking about medial malleolar fractures. If there are bimalleolar fractures, meaning both sides of the tibia, they usually require an open reduction internal fixation. Trimalleolar means the medial and lateral side of the tibia as well as the fibula. And that's, usually that you get that involvement of, let me go back to bimalleolar. Bimalleolar is medial and lateral malleoli, and that usually requires ORAF. Trimalleolar is involving the posterior lip of what we call the tibial plafond, and that also requires an ORAF. Typically, these individuals require 4 to 6 weeks of non-weight-bearing ambulation, and when rehab, we include, we tend to have challenges in these individuals because they have limited closed chain dorsiflexion. We see a lot of weakness, and we see corresponding gait deficits, especially because of the lack of closed chain dorsiflexion. So when we are looking at their gait, just to give you some, you guys remember this from biomechanics and kinase 2, but your step length, typically approximately 15 inches. Our base of support should roughly be 2 to 4 inches wide. Our center of gravity is in the middle of our body to our lower sacral region, and it, varies about 2 inches. It goes up and down about 2 inches as we walk. When we shift a little bit laterally, if we shift it, when we're on both of our legs, it's centered, and when we are on one leg, it shifts a little bit to the left. If there's weakness on the weight-bearing side, we tend to see a shift of weight that is too far. During gait, the pelvic rotation with each step, we get about a 40-degree forward and back as the hip acts as a fulcrum for rotation. So what do we typically see, especially with ankle pathology? So ankle dorsiflexion, lift the toes with each step, or you drag the toe. The patient will bend their knee more to clear the foot. And you may also hear the foot slap because the anterior tib is not controlling the foot to lower it to the ground. If there's problems with the gluteus medius, we see that Trendelenburg gait, and the upper trunk shifts to that weaker side. If we have glute max weakness, we see that the hip, we push the hips forward, the shoulders are down and behind your center of gravity, moves behind you, which is not efficient. If we see weakness in the quadriceps, we see knee hyperextension during weight bearing. We can see discoordination or an inability to control multiple joints. Here we're trying to look at multitask type activities where you have to control balance and coordination at multiple joints. So maybe standing and touching the nose, touching a finger. We may see a ataxic gait, which looks like shakiness or a tremor or small steps, as if they're walking on ice. What are some of the things? These are just some general, and obviously when you took biomechanics and kinese 2, you had a lot more ideas here. But some of the treatments, when you see gait dysfunctions, you could certainly work in parallel bars that provide support, and then take smaller steps, outside the parallel bars with support, moving into larger steps with support, and then smaller steps without support, and then larger steps without support. You're, I'm sure, aware of locomotor training. That is designed for recovery for individuals with central nervous system injury or disease. These are for patients who are medically stable following this diagnosis, and they can certainly benefit from locomotor training. Usually you see that with spinal cord injured individuals, Asia C and D, incomplete, certainly stroke, traumatic brain injury, maybe patients with CP or multiple sclerosis or Parkinson's disease. In terms, for gait training, a lot of times we might have to do activities to increase trunk rotation, increasing that arm swing, increasing hip and knee flexion during swing through, activities to control increased weight shifting from right to left, especially if patients have a painful limb. They tend to not shift as much of their weight toward that involved side. As you know from your modalities course, you can use NMES to try to facilitate contraction of a weak muscle, or a functional electrical stim, partial body weight support, and like I mentioned, body weight support for locomotive training for those individuals with SCI or other central nervous system disorders. Don't forget, when you're documenting gait, you need to think about distance, device, weight-bearing status, level of assistance, the surface that they're working on, and the speed of that gait. Don't forget, your eyes will give the greatest qualitative assessment, and those are the things you're usually identifying as what you're going to work on in your treatment to improve. This is just giving you a picture of some of the locomotor training, which I think you've already seen on one of your ICEs. As we mentioned, in individuals with chronic ankle insufficiency, but quite often this occurs in any kind of ankle pathology, we tend to see balance impairments. So this just gives you kind of a progression. You could start in sitting, working on static and then dynamic, and then get them upright as soon as you can. First starting on static balance, meaning having them just stand still, and you kind of try to see if you can perturb them to get them to lose their balance, and then work on dynamic activities. We start with bilateral two-legged exercises on level surface, moving to uneven surfaces, and then have them multitask, maybe standing on both limbs, catching a ball, from different directions. Once they look pretty good with that, get them on unilateral lower limb, starting again on level surfaces, moving to uneven surfaces, and then multitask, having them maybe be on a trampoline on one leg as you're tossing a ball to them. You want to look at quality of movement. Where are they controlling the balance from? Where are they getting their movement strategies? Is it from the trunk? Are they using a lot of their arms? Are they trying to avoid movement at the ankle or the knee or the hip? You want to make sure that they're continuously being challenged, but they're able to maintain a good base of support. You can certainly make it even more hard by having, or progressing it, by having them do it first with eyes open and then with eyes closed, change the surface, and like I indicated, have multi-task type activities. These are just some of the things that we have, certainly in the South classroom, but there are many, many other activities out there that you can do you don't need to have special equipment. You could have them do this on a pillow or a couple of pillows. Just make sure that it's safe for your